Welcome to Washington Hospital Today, dedicated to informing residents about healthcare topics and issues. Through programs featuring community forums and free health and wellness classes, our goal is to empower community members with the information needed to make informed health decisions. Washington Hospital has been providing healthcare to the residents of the Washington Township Healthcare District for the past 60 years. Hello, welcome to today's presentation, Lung Cancer Detection with Low-Dose CT, presented by Dr. Sunil Upender, radiologist, and Denise Lee, lung cancer survivor. First, we will begin with Denise Lee. Denise was diagnosed with lung cancer 5 years ago, and we are happy to say she is now cancer-free. Denise is here with us to share her story of diagnosis through early detection and survival of lung cancer.
Thank you again for the opportunity to come in and share my story about early detection and low-dose CT scan. Whenever I'm asked to share my story, I basically boil it down to 4 words: a billboard saved my life. And that's essentially what happened. I started smoking when I was 14. I quit for good when I was 54, so that was about 40 years. And it was absolutely the hardest thing I had ever done in my entire life. And shortly after I quit smoking, I was driving home from work on Highway 880. I worked in San Jose, and I lived in Fremont, right here locally. And I was driving home, stuck in traffic, and I looked up and I saw a billboard, and the billboard said, if you are currently smoking or quit within the past 15 years, that this simple test might save your life. So after I saw the billboard, I went to my primary care physician because I had to have my annual physical. And during that time, I asked her, I said, I saw this billboard on the side of the road about early detection, and I'm just wondering if you can order this test for me. Then I went and had it, and the next day I got a phone call from a pulmonologist. And the pulmonologist said we found a mass in your upper left lobe. And after some testing and some scans, I was diagnosed with lung cancer. And at that time, the doctor thought it was stage 2B or 3. And after I had my surgery, I had a lobectomy. After my lobectomy, a couple of weeks later, I started chemotherapy. And after chemotherapy, I found out that I was eligible for a clinical trial. And I participated in the clinical trial for a year. It was an injection once a month for 12 months. And then after that, I asked my oncologist, what do I do now? And he said, you go out and you live your life. And one of the things I've discovered is that, people always say that lung cancer is the deadliest form of cancer there is. And that has a lot to do with the fact that usually by the time you have symptoms or it's discovered, it's spread so much. But lung cancer doesn't have to be the deadliest form of cancer around. And the reason for that is because we have early detection. And early detection really did allow me, one, to have surgery because it was caught early enough that the doctors, and I was young enough, and the doctors were able to remove the upper left lobe. 2, I was able to have chemotherapy in a particular area. And 3, I qualified for a clinical trial. So with all of the advances in lung cancer treatment, it's just really amazing, and it's really uplifting that there's so many opportunities, there's so many treatments available if lung cancer is detected early. So I am a firm believer of the low-dose CT scan. Once again, it's really easy. I'm a firm believer of early detection. For me, I didn't want a lung cancer diagnosis. That was the last thing that I wanted, but I was so glad that they caught it early because I had so many different treatment options that were available to me that otherwise would not have been had my cancer been detected at a later stage. So thank you so much, and go out and get tested.
Thank you, Denise, for sharing your personal experience with our audience. And now I would like to introduce Dr. Sunil Upender, radiologist with Washington Radiology Medical Group. Dr. Upender is the medical director of imaging and the chairperson of radiology at Washington Hospital. He is board certified with the American Board of Radiology in diagnostic radiology. He completed his residency at Norwalk Hospital and his fellowship with the Yale University of Medicine in body and breast imaging. He specializes in a wide variety of image modalities, including PET and CT, ultrasound, CT, MRI, fluoroscopy, CT perfusion, and nuclear medicine. Please welcome Dr. Sunil Upender.
Thank you for that introduction. And thank you, Denise, for sharing that powerful personal story and your journey. And I'm glad that things are looking great for you now. And as Denise mentioned the importance and highlighted the importance of screening and early detection, we will be talking about lung cancer screening utilizing a low-dose CT scan of the chest. So just some background. Lung cancer is the second most common cancer. Breast cancer is more common than that, but there's approximately 230,000 cases a year of lung cancer that's diagnosed. However, it is the leading cause of death. As Denise mentioned, the symptoms often develop late when the disease has already spread. So there's approximately 135,000 deaths per year. And the 5-year survival is quite poor because of that, with only 17% living at 5 years. But with early detection, we can increase those numbers. We can get that up to 64% if we look for these lung nodules or masses that may turn into cancer or spread elsewhere in the body. So just some risk factors for lung cancer. These include mainly cigarette use. 90% of all lung cancers are attributed to cigarette use. If you smoke, you do have a 20% increased risk of developing lung cancer. And this could include even smoking marijuana or vaping. So fortunately, cigarette use has come down or is coming down, but the utilization of vaping has gone up, especially in the young population. And just like Denise, who started at 14, the young are often targeted, but this becomes a long-term adult problem. Additionally, aging is another risk factor, as is background radiation, particularly from radon, which gets trapped in lungs, and that comes from the soil. So what can we do? We can obviously quit smoking, and we could detect nodules or cancer early. And here is a small nodule in the right lung base that wouldn't be seen on a chest x-ray. It wouldn't cause any symptoms just because it's too small. It's not central in location. So this could go undetected till it's already spread. So if we can detect this early, we can get that number up, as we saw before, from 17%. So there is a panel of experts called the United States Preventative Services Task Force. So in 2013, they made some recommendations on lung cancer screening, and they recently updated that in 2021, which is fortunate because now it includes even more people that are eligible. And it includes patients that are aged 50 to 80 and that have 20-year pack year smoking history. And what that means, you just multiply the number of packs of cigarettes you have a day by the years you smoke. So if you smoke 1 pack a day for 20 years, then you have the 20-pack year history to be eligible. Additionally, you do need to be a recent smoker or someone that has quit within the past 15 years. After that time, the benefit or the risk has decreased quite substantially. Now, with these criteria put out by this task force, 14 million Americans qualify, and which is great, but unfortunately only 5.8% average are actually utilizing this exam. And some states are better, like Massachusetts, but unfortunately some states like California, only 1% of all people that qualify are actually getting this study done. And why do you want to get this study done? It's to reduce mortality. And if you do this screening program, there's a 20% less chance of developing lung cancer. Now, if you're wondering if insurance covers it, it does. Basically, that task force has made the recommendations to the government, including Medicare, and private insurances also cover this fully. For Medicare, there is only one little difference. They do require you to be 77 is the maximum years that they're covering. Additionally, you do want to be asymptomatic and not show signs of lung cancer. And if you do show signs of lung cancer, there's other tests that could be done instead of the screening tests. So there are some eligibility criteria for the radiologist, such as myself, who will be reading the exam. We do need to be board certified in diagnostic radiology. We need to interpret over 300 CTs in over 3 years. So we have to continually be reading chest CTs, and we have to have documented continuing medical education. Similarly, the imaging facility that is performing this study, such as Washington Hospital, needs to meet certain criteria. And the main criteria is to perform the CT with low dose. So there's some tough thresholds that we want to maintain for patient safety, because this is going to be a screening exam that's going to be repeated year after year. Additionally, the imaging facility needs to ensure that the proper types of reports are being put out, and they do collect some data and submit it to a national registry. And that registry will keep track of whether the patients that are undergoing this exam are appropriately screened, whether the radiation dose is appropriate, and also if the reports are what they should be, which is a standardized report that I'll be getting into. So how this begins is you make an appointment with your physician, your regular physician, and have a counseling visit. And there's a number of things you want to discuss. First, your physician will discuss whether you meet the criteria, the eligibility criteria for the exam. Second, there's a shared decision process where the physician will discuss, why they think this is a good study for you, talk about risks and benefits, and also take in your personal preferences and beliefs. So, it really becomes a shared decision whether you want to do this. But if you do, then your physician will talk about, adhering to this program and annually sticking with it for the long-term benefit. And additionally, there should be counseling you also on smoking cessation, because that is the best prevention. Following studies, following years, it's easier. You can just see your doctor for any other visit that you're there for, and just say that you want your next study, and as long as you meet the eligibility criteria, you'll get an order for that. There is this nice website that's easy to use called shouldiscreen.com. It's got some information about lung cancer screening, and it has a nice little calculator where you can plug in your age and smoking history and things like that will help determine whether you're a good candidate and if this is a good study for you. And you could do that even before seeing your physician. So now that you have the order for the exam, you call an imaging center and you undergo a low-dose CT. And here's an example of it. the patient lies flat on a table, and the table goes in and outside of this big donut. It's pretty spacious and quick. And so that's the beauty of this. It's only 30 seconds and you'll be done, and you've taken a huge step towards helping your health. The next step involves where I come in, and that's where the radiologist will review all those images and come up with a report and a recommendation on what the next steps are. And this is strictly outlined on how we should report this. There is a standardized template that we need to utilize. And this just makes it consistent between reports from one year to another, or if you go to different imaging facilities, so everybody's on the same page. And then there's a easy way for you and your physician to know the end result, because we give a score at the end between 0 to 4, and that tells you what we think of any lung nodules and what the next steps are. So the scores start from 0 and go up to 4, with 4 being the most worrisome. A score of 0 basically means we don't have enough data, and we may request some additional imaging or comparison to some prior studies. So we just can't give a definite answer yet. And a score of 1 is, this is an example of a lung nodule right here. That is a 1, so 1 means that there's no lung nodules, or it's clearly benign. So this one has this low attenuation in the center, which tells us that that's fat. And so this is a benign growth called a hamartoma, so nothing to worry about. It has so category 1 lesion has less than 1% chance of becoming malignant. Here's an example of a category 2 lesion, which is right here in the right middle lobe, and that is also benign. And here's some more examples of lesions by the arrows that are benign lesions. This has a 1 to 2% chance of malignancy, so still very low. We're not worried about it, and it'll either resolve or won't develop into cancer. Then there's lesions such as this one, circled right here, that most likely is benign, but we can't be 100% sure. So what we'll do, we'll recommend a short-term follow-up. And here now we're starting to get into the worrisome category. So there's 4A and 4B. So 4A, there's this lung nodule right here. It has a slight irregularity, and the size is a little big. So now we're getting worried. We may recommend some additional tests. Here's another lesion that's actually within the airway, which is a 4A lesion. This is a 4B lesion. So now you can see these little tails. This is a cancer that's infiltrating into the lung. And for this, we give it a 4B, where we are worried. There's a greater than 15% chance of being malignant, and we'll probably recommend a biopsy. Sometimes we may use additional letters like 4X, and that is basically, it's a 4 lesion, but there's some additional findings such as these enlarged lymph nodes, and that increases our concern for malignancy. Sometimes we may put an S modification, and that basically means that there's something that's not lung cancer, but it is still significant, and you and your physician will need to continue following that up. And then a modifier C would be basically having a prior diagnosis of lung cancer and then returning back to the screening program. And this just kind of gives the probabilities, as I mentioned. And the 4A is basically 5 to 15%, and then the 4B is greater than 15%. So now that you've done the test, the report is done, you make an appointment either to see your physician or you can check online to get the results. And the results will give those numbers that we just went over and also the next management steps. So you could be 1 and 2 again are benign. So that basically means you'll come back in a year and have another CT scan, a low-dose CT scan. If it's a 3, which is probably benign, but we're not 100% sure, we'll do a 6-month follow-up. And if that's stable after that time, we'll probably just return you back to the annual screening. Only if there's some change or something that's worrisome will we potentially change that ranking. And then if it's a 4A, we will often recommend additional studies such as a routine chest CT with contrast or a PET CT to see how it behaves. And then if it's a 4B, we'll probably recommend a biopsy to really get some tissue diagnosis. Fortunately, this blue is a score of a 1 or 2, so most of the lung exams that you'll undertake will fall into this category. So that's good news, 90% fall into that category. Then there are 4% in this yellow that fall into probably benign. And so then it's just a small minority that is the suspicious 4 lesions. So either 4A or 4B, and recommending the tests or biopsy, respectively. So now that you've had the exam and you might have it for multiple years, you might be worried, are you getting too much radiation? But the beauty of this study and why it can be a screening exam is that it's such a low dose of radiation. If you have back pain and you've just gone in to get an x-ray of your back, it's the same radiation as that, which is just a small amount. And your chest gets most of the radiation, and then the rest of your body will get even less because it's not in the field of view. Here's a diagram of different radiation exposure. If you look at right here around the middle, at the level of 1 millisieverts, this is kind of the background radiation. This is just normal stuff that is just coming in from space, from the Earth. And so basically, this is where the low-dose CT falls in between. So it's less than even what you get in a year from background radiation. Other parts of the country, such as Colorado, are even higher up here with their background radiation. And it is, compared to a normal CT scan of the chest, which is up here, this is, a seventh less. So even if you underwent, per the recommendations, started at 50 and had an exam every year for 25 years, your risk of developing any cancer from the CT scan would be only 0.85%. And that's over the expected lung cancer risk, which is at 17%. So this is almost negligible. There are some additional risks with this procedure. Mainly, we can't always tell whether something is cancer or not. So there will be some false positives where we think it's suspicious, but it turns out not to be. There are some incidental findings that often are helpful, such as like coronary artery calcifications that may still help, but will add some potential further workup or anxiety. The more you know about your body. And then there is the potential that you'll have a biopsy. Again, these are all minimal, and hopefully most of your exams will be normal, and you just continue screening that way. So if everybody does this, of all the 14 million Americans that qualify, we can save 20,000 lives annually, which is a huge percentage of actually the 130,000 that get the cancer. So as Denise said, we really need to get out there and do these exams. And Californians in particular, as this diagram shows, there's just so many patients that could be getting this study, and it's such a simple study. It's quick, it has negligible risks, and it can really save lives, as it did for Denise. This is our data from our hospital, and it shows basically since we started this program in 2016, there are 378 cases, which again, it goes back to that prior graph that just a lot of Californians aren't getting it. We do a lot of other CTs that are normal dose of all different body parts, much, in the thousands volume. So this is definitely an underutilized study. But even with that, we were able to find 3 cancers. So we affected, many people's lives, but particularly these three patients. So, as Denise said, get out there and get this if this is applicable to you. And I'll conclude my talk here and answer any questions that you may have. Thank you.
Great. Thank you, Dr. Upender. We do have some questions. The first question is, with so many people that are eligible, why is there such a low percentage of people who actually do this screening?
That's a great question. And there's different reasons, but I think there is a taboo with lung cancer. People feel like, is it their fault with smoking? And I think there just isn't the same media attention as there is with, for example, breast cancer. And that's great that breast cancer has that. And it too, in the 70s didn't have the same momentum behind it, kind of like where we are now with lung cancer. And quickly, between education and public awareness, breast cancer screening has become highly successful, and a lot of patients are doing it. So I think it's a little bit of lack of knowing about it. Like Denise, had to go by the, that billboard, which was great, but there are, just needs to be more billboards, more talks like this, and more just awareness, and I think that will help increase. And because it is working in other states, and I think those states are, such as Massachusetts, are probably being more proactive about it.
Thank you. And the next question is, or it's a statement, I'm claustrophobic. Will there be a problem for me getting screened with the CT?
So that is a common question. If you remember from that picture, the donut that goes around you there's a lot of space between you and the donut. So most patients have no issue. I know with MRI that can be a concern because the imaging donut that's around you is much smaller. There's a lot less space. But here there's a lot of space, and the beauty is that you're in and out in 30 seconds. So rarely, even patients that are claustrophobic, rarely do we ever get a bad study. So we're able to do even the most claustrophobic patients.
Great. And the next question is, what are some symptoms of lung cancer?
So lung cancer symptoms, again, do come up pretty late. And so that could be a cough that just doesn't go away. It could be a bloody cough. You could be short of breath. You could just can't exercise as much. There could be weight loss. So, these could be a lot of other issues. So it can throw your physician and you off on a tangent for a couple of years till you actually get a chest CT. So again, those are the symptoms, but the advantage of the screening exam is that we start this before there's any symptoms and find these cancers when they're small.
Okay, and the last question, can you remind us again who qualifies for low-dose CT screening?
Okay. So Medicare, private insurance companies they may accept a wider age range, but Medicare basically recommends 50 to 77 years of age, and that you've had at least a 20-pack smoking history. The previous recommendation to 2021 was they wanted 30-pack year history. So now it's only 20-pack year history. And also to be a recent smoker. So having quit within the past 15 years are still smoking.
That's great. Thank you, Dr. Upender, for the information. And this does conclude our program. Thank you again for this insightful presentation, and thank you, viewers, for tuning in. The entire broadcast of today's presentation will be available on our Facebook page and YouTube.